We are live.
Good evening, honorable faculty and dear friends. Welcome to the Forearm Fracture Symposium. This is the 6th symposium of the summer season since June. We are having with us 3 stalwart speakers and all of them are from Maharashtra. It is my proud privilege to introduce them to you. We have with us the seasoned trauma surgeon and president of Maharashtra Orthopaedic Association, Dr.Wasudev Gadgone. He is a renowned speaker, widely traveled, and he presented his works in various state conferences and workshops. He is also visited our state conference at Jim Corbett. He has many innovations in orthopedics, including his nails for forearm fracture, forearm bones. Today he will be speaking on nailing in forearm bones. Welcome, sir.
Dhanyavad.
The second speaker of today is Dr. Sangeet Gawhale, the multi-talented surgeon from Mumbai. He is ex-president of Bombay Orthopedic Society. He has been speaker and faculty in more than 175 conferences and workshops. He is currently honorary professor at Grant Medical College and JJ Group of Hospital, Mumbai. He will be today taking on complex trauma of forearm fractures with plates. Welcome, Dr. Gawhale. Today we have here with us teacher of teachers and most loved speaker, Dr.DD Tanna sir from Mumbai. A Gujju by birth, he is the most loved speaker in any conference. I am fortunate that he agreed to my request on first phone. As no introduction is able to describe him fully, I welcome Dr. Tanna sir in this symposium, and he will be dealing with the complications in forearm fractures. Welcome, sir. We have with us Dr. Vimal Nautiyal, our past president of Uttaranchal Orthopaedic Association from Dehradun, and Dr.Neeraj Jain from Jhansi as panelists. We welcome both of you, sir. We have with us Dr. Puneet Agarwal, our dynamic state secretary with us. Welcome, Dr. Puneet. We have with us Dr. Neeraj Bijlani from Ortho TV, who is instrumental for the whole series. Welcome, Dr. Neeraj. Now I would request Dr. Wasudev Gadgone to go on with his talk, nailing in adult forearm fractures.
My screen
Dr. Gadgone, please.
Sirohi, my screen is visible?
It is a little slow, sir.
Is it visible now?
No, screen is visible, but you are a little slow to speak. The volume, increase your volume, sir.
Okay.
Make it full screen, sir.
No, I will.
Previously it was full screen.
No, I am trying for this slideshow.
Slideshow.
No, it is okay. Slideshow is there. There is no problem for it. Okay.
Yes, it is okay now.
Okay. So, respected Ashok Shirohi sir, for the invitation of Uttarakhand Orthopaedic Association educational webinar, and other faculties from Uttaranchal Orthopaedic Association, respected Tanna sir, and the other faculties, those who are present here. So I will be talking on nailing in adult forearm fractures. But Neeraj has asked me whether you do a plating also. So I told him that I have all attended the courses of UO also, that plating, primary, advanced, everything. So I do whatever the case comes, I do plating also. And I am not against plating of forearm fracture. On the contrary, forearm fracture plating is a gold standard method. So literature is grossly inadequate about the nailing. Even Google failed to show convincing references regarding nailing in forearm fracture in adults. So we are in a chakra view, whether to operate of a both bone forearm fracture by nailing. So we are now discussing here, and we are in the chakra view, what to do, whether to do a nailing, plating, or hybrid fixation. And then these are the fellows, those who are on the screen, they want to get answer from, and none other than the this Bhisma Pitamaha, Dr. Tanna sir. So he will summarize what is to be done, whether the nailing is a preferable or a plating is a preferable treatment, or one which is the gold standard treatment for adult forearm fracture, because majority of the viewers as well as the faculty also in confusion when the fracture comes, whether to do a plating or nailing. So anatomy of the forearm fractures. The radiation ulna have an important role in positioning the head, and the ulna has a stabilizing role. The radius is articulated in a way which allows it to roll over the ulna, moving the hand from supination and pronation. That is the most important movement which is responsible for the day-to-day activities of the daily living. Fracture of the forearm is stabilized by one of the three systems of fracture fixation in adults: compression system, splinting system, and hybrid system. Intramodular fiction belongs to the internal splinting system. Splintage may be defined as a construct in which micromotion can occur between the bone and implant, providing only relative stability without interfragmentary compression. In this technique, bending movements are neutralized, but the telescoping and rotational torsions are not prevented. However, telescoping movement is conducive for fracture union. Fracture heals by secondary intention, that means with the callus formation. But crux of treatment of forearm fracture is the restoration of the radial bow. Is important for restoration of a normal architecture of the forearm, and that is mostly responsive for rotation and grip strength. Hence, non-operative treatment is not advocated. What is the treatment left is only internal fixation by nail or by plate. Most accepted method of the forearm fracture is open reduction and internal fixation by plate. It's because textbook says that the fractures of the forearm should be treated as an intra-articular fractures, and there is a substantial literature supports and evidence that this should be treated as a intra-articular fracture. Hence, perfect anatomical restoration by open reduction and plate. But however, the plate and screw, as you know, they are extensive skin exposure, periosteal stripping, compromised vascular supply, increased operative morbidity, infection, refracture, removal of the plate. These are all complications we face after doing a plating system. Intramodular fixation. Russ brothers' first theory is a 3-point fixation. In 1940s and early 50s, diphygeal forearm fractures were treated by nailing with K-wire and Russ pins. Very good results are reported in literature, but failures are also there. So, yielded a poor result due to lack of stable fixation by subsequent authors. If the Kutzner principle of filling the canal is to be followed, then what will happen? Straight, rigid nail could not meet the all the necessary requirement for restoration of the radial bone. That is the most important crux of treatment in the forearm fracture. Therefore, a dilemma always, but intramodular nail fixation, a restoration of radial bow was introduced by Sage way back in 1959 with the development of the pre-bent nail system. This has already been reported in literature bone and in 1959 with a very good results. The first oversized straight square-shaped rim nail was developed by Street in 1954, and in India, it is propagated by Dr.AK Talwalkar Mumbai, designed and propagated square nail, and I think it is widely used in all over the India, though there is not much literature support and big series of publications. Union with a good callus polarization, relative stability. There are 3 to 4 papers are already published about this method. Marek and Talwalkar achieved 100% result. Khare et al. Showed union of 95. Moda et al. Observed 95 union rate with square nail. And average period of POP immobilization was near about 6 weeks. Diphygeal fracture of the forearm in adults, whether to do a plating or intramodular, which is better treatment. So in comparison, it has been seen that the open reduction and internal fixation with compression plate is the gold standard, no doubt about it, and it is 95 to 98% union rate. And internal fixation with the square nail of a Talwalkar is 92%. There is only a 6% gap is there. But pitfalls of unlocked nail, stress rigid, thick nail could not restore the radial bow, as I said. Jamming of the nail and splitting of the shaft can occur. Thin nail permit rotatory and substantial lateral motion at the fracture site, breakage of thin nail and implant migration before union. The most important complication is a painful prominent hardware, ulnar bursitis, non-union, malunion, restricted motion. And with this, it has gone into disrepute for near about 50 years in the orthopedic literature. When then with newer nails, interlocking capability and enhanced anterotional stability, literature reported their union rate is 95 to 100%. It is comparable to the plate. And in last 20 years, various nails are propagated all over the world. A distinct advantage prevents shortening in metaphyseal, comminuted and segmental diphyseal forearm fracture. Previously, it was thought that the comminuted fracture nailing is contraindicated. So, but interlock nailing is a technically demanding procedure, and there is always a possibility of injury to the posterior intracessus when you do a proximal locking of the nail. So a new concept in the treatment of forearm fracture, which is designed by me, 96% excellent to good result. And this is known as a screw intramodular nail. It is nothing but the thallam nail. And it is available in 2.5, 3 mm, variable length, titanium or steel. A threaded end at the end of the nail, and this is very important. It fits into the metaphysis of the radiation ulna, and it can be screwed into the metaphysis with the screwdriver. Screw is placed at the end of the bone to prevent migration, and you can see here how it can prevent the migration, which is a major concern in the thin nail. So this is an example. You can see restoration of the radial bow by intramodular nail. And this is the both bone forearm fracture, very unstable fracture. You can see a perfect anatomical restoration radial bow. But we have to use elastic nail for restoration of the radial bow. So it should be not more than 2.5 to 3 so that it can mold it according to the cavity of the bone. Now, how to do it? A procedure nail mounted on a chuck. The insertion should firmly grab the nail in order to control insertion and nail withdrawal. Bowing of the radius can be achieved by the proper contouring of the nail. And these are the close reduction is achieved by longitudinal traction and direct pressure at the fracture site. You can use a forearm distractor also. Assess the length and diameter of the nail. Closed or K-wire assisted reduction. If you are not able to do a reduction by closed meter, you can use a mini open reduction in 10 to 15% may require this type of a open reduction. Ulnar nail entry at the tip of the olecranon, or you can also take from the side with the help of Steinman pin or a bone hole. So this is how this is the entry point. You can see here how I give it. It's a very simple thing. You can do a small stab incision, then you pass a Steinman pin, and then this dilate the proximal opening. Use a straight awl, and then after this you can reaming of the canal can be done. And this is mostly radius or ulna nail is a ream nail, and K-wire assisted reduction. You have to stabilize the fracture with hand or sometimes with the K-wire, and then insertion of the nail. By this is because why reaming is required. It is because we have to do a reduction, so that sometime manipulation is required. That there should be a free movement of the nail. So this is how it is. As soon as the nail tip goes into the other side, you will get some stability, and then you can pass the nail. So this is how it is. And radius entry, there are two entries at the silite process, and other is at the medial lateral to the lister tubercle. You can take any one of the one, but I usually take a radial stylite between tendon of external carpi radialis longus and pollicis brevis. So incision is dilated, a small stab incision given, and then with the artery forceps you just dilate the incision till you reach to the bone, and then you pass a curved bone hole into the medullary cavity, check it into the C-arm, and then after this reduction, sometimes it is very difficult to pass a nail through the isthmus, so that probably you may ream the radius canal with the flexible reamer, and you can do this thing with the flexible reamer, and then you negotiate the nail, and after negotiation of nail you will reach to the fracture side, and last threads are then you can screw. So this is how we have to do it. Use a percutaneous K-wire to assist in the reduction in a displaced fragment. This is how a ulnar nailing was done. There was a translation of the radius, and with the assisted K-wire we can reduce the fracture, and then you pass the nail. So reduction, reaming of the nail, insertion of the canal, and lastly you can thread this, you can just put this into the metaphysis. That is the most important, so that it will prevent the migration. Traction is released, nail is forwarded, tip of the nail you can see here in the subchondral bone, here in the subchondral, actually 2 to 3 threads we have to keep it out, so that for the removal there is no problem. And before closing the wound and everything, you must compress the fracture. So whatever the distraction is there, that will be corrected, and impaction will occur, and you can also take the movements of the wrist. So this is how in a disparity of the canal, you pass a first reduction nail, and then you pass a smaller nail to jam it, so that the translation of the fracture fragment will be prevented. And you can see here in this program, in the diagram, how the translation of the nail, because there is a disparity in the canal, and you can see here how translation of the nail can be corrected by the smaller diameter, as well as the some small length rust nail also you can use. And you can here see the stack nailing, wherever it goes you have to keep it short and then cut it. So this is how it is. The translation of the radius, it can be corrected very well by putting a stack nail. So disparity of the canal, use a stack nail. Entry point radial to the radial side of the lister tubercle, everybody knows about it. You can use that also, there is no problem. It's a surgeon's choice. So nail was introduced from the metaphysis toward the medulla using the second nail with the help of bone hole. And you can see this is one of the example where entry lateral to the lister tubercle, but I usually prefer to do it from styloid process, mostly closed procedure, cosmetic surgery, 10 to 15% require a open reduction, elbow, above elbow cast for near about 4 to 6 weeks. These are all example, fracture at the same level. I don't deny that the plating is the treatment of choice, but I want to emphasize today, this can be treated by nailing. So you can restore the radial bow, fracture at the same level, and you can see how the fracture nicely united with full function. Another very distal fracture, fracture as united full function. So I can, there are so many cases are to shown, but I will restrict to some of the cases only. Now you can see here how a disparity canal is packed with a very small and thin nail, and radial bow is restored, and you can see here how a stable reduction is achieved. Most unstable fracture, stack nailing. Another example, you can see a stack nailing is done, and this is a very small paper, a single case report was there. There are so many cases I did it, but they say it avoids plaster immobilization after nailing and it gives a stable fixation. In a comminuted fracture, if length is maintained, how the length is maintained? It's because it is the proximally, it is in the metaphysis and then in the subchondral bone. So there is no place for a compaction, and therefore the length is maintained, and whatever the small fragment, if the length is restored, they heal around the nail, and bone grafting is not necessarily. This is one of the example you can see here, very comminuted fracture, subchondral insertion, metaphyseal migration is prevented, and the fracture has healed. If the canal, if the everything heals around the nail, if there is a stable fixation. This is a revision surgery, failure of the plate. You can do again a plating and bone grafting, but I resorted for Nicholas technique, and then I did a nailing, and everything has incorporated, and tricortical strut graft for non-union. This is another example, revised with the stack nailing, and you can see union, and there is some limitation of movement is there, but patient is fine. This is the ulna fracture, isolated radius fracture. It's a very, very good treatment for isolated radius and ulna fracture. Only there is a reservation for a Gallagher fracture, but that also can be done nicely. So against nailing, nailing of the forearm will achieve the relative type of stability to nail. Hence, plaster cast is required. Plaster causes permanent stiffness of a joint, and rehabilitation takes longer time. That is the against nailing. But what is my view? Plaster causes a permanent stiffness of joint is a myth. An uninjured joint never gets stiff. If immobilized up to 6 weeks in any form of splint or plaster, and this is John Chanley in his textbook of fractures of the this conservative treatment of the fractures. Incomplete reduction of produce a distraction of the other side. It's a very true fact. Ulna is relatively straight bone, so no issue in nailing. Simple principle, 3-point fixation, thicker rim nail to prevent back out. Problem is with the radius to restore the radial bow. If you don't restore the radial bow, then there is a problem of disparity of length. Caution, eccentric entry. Use a prevent 2.5 nail to restore radial bow. In clinical practice, it is rarely observed, but with a careful thumping and compression, distraction can be reduced. Loss of radial bow leads to restriction of rotation. Some loss of radial bow, myth, good union and full function at the 4 months. Example of some loss of radial bow, you can see this is a segmental fracture, close reduction, 12 months follow-up. You can see everything is restored. General observation, some terminal restricted movement may be lost, RMO may be lost, especially in supination of the forearm. but the majority of the work which can be performed without full supination. And over the period, they compensate. And you will find very, very rarely the full supination movement is required. It is mostly a mid-prone position. And you can see here all routine activities. There is, you will find that this is this. So proposition, when both forearm bones are fractured, if the radial bow is lost, ulna and shoulder probably adapts to allow full rotation. And in isolated radial shaft fracture, it is probably more important to retain radial bow, that is in a Gallagher fracture. So how it compensates, you can see here with this video, you can see here how, and this is how it is. It is getting compensated in the elbow and in the shoulder joint. So you can see here how it is compensated. Therefore, some loss of supination can be compensated by elbow and by shoulder. So this is how it is in graphically, but nailing is not always indicated. Nothing always works in a highly comminuted fracture. Fracture at the ends of the bone. Backing up the nail and bursa formation, they do occur. Early removal nail is essential, otherwise removal is difficult because of the serration in the screw osteointegration in the metaphysis may occur. Therefore, I advise that after healing of the fracture, that nail should be removed. So non-union of radius, sometime you do get here, it is that as the phenomena has occurred, as I described here, ulna is united, radial bow is lost, and there is unstable construction, restoration of the radial bow, and the fracture as united. So literature grossly inadequate. Even Google and PubMed failed to show enough references regarding nailing in adult both bone forearm fracture. Meticulous record of operated patient by me is Google and PubMed for me, because I have done number of cases with a good follow-up, and you can see these are all old records. These are the things now I stopped keeping the records also. So I have done number of them, and then in conclusion, intramodular nailing of adult forearm diaphyseal fracture appears to a good alternative to plate osteosynthesis. Plate fixation versus intramodular nailing for both bone forearm fracture meta-analysis and control trials, IM nailing is associated with shorter operation time and lower complication rate as compared to the open reduction and internal fixation World Journal of Surgery. And this is the Journal of Injury. It's a very reputed journal. So mini-invasive biological method of fixation, you decide. Open or closed surgery, choice is yours. Choice is yours. Advantages of intramodular nailing, 3-point fixation of elastic nail, implant stress sharing beware which leads to secondary periosteal callus formation, as you can see here. No chances of refracture, mostly scarless cosmetic surgery. Implant migration prevented as screw fits into the metaphysis of radius and ulna. Biological method of forearm fracture by screw IM nail results are comparable to plating. You also make your choice for nailing in next case. I assure you, you shall never regret. Close nailing is an art. Just practice it. Practice makes the man perfect. Don't go on literature that nailing does not work in the forearm fractures. Take home message. Past was the plaster. Present is placed. In future, it will be a closed intramodular nailing because patient wants a cosmetic surgery without any complication and without any big scar. Thank you very much.
Thank you, Dr. Gadgone, for advocating your case for the nails so vociferously. Dr. Sangeet has joined us. Can you hear us, Dr. Sangeet Gawhale?
Yeah, but my problem is my picture is vertical instead of being horizontal. I'm asking Neeraj.
So are you speaking from the iPad?
No, sir, from the MacBook.
ये ऐसा कैसे हो गया संगीत?
I don't know. I am on the ground always.
अच्छा.
I'm never vertical in the evening.
I think if we can discuss Dr. Gadgone's case first before we switch on to Sangeet. Anybody
Okay, sir.
has a question to Dr. Gadgone or anybody has an opinion to Dr. Gadgone? Because as I said, I think I would like to talk about it. I was a plater all the time. And on my admirers, some of the people whom I respected, twice or thrice I went to their city and they showed me, I'll talk about three people. One is Dr. Chandok. When I went to Nagpur, gave a talk. He collected some 8-10 cases of daily, kept them outside, and he said, "Sir, I want to come and see them." I saw them, and I was quite surprised. They had a very good result. That same thing happened in Amravati when I went to see him. Same thing he told me, "Sir, you are talking about training all the time. Just see these results of training." And after this 2-3 experience, I changed over to a nailing majority of the time. But I don't do nailing alone. In my presentation, some of those cases where I'll be talking about, the nailing is probably inferior to training. But nailing is a very good closed method or a mini open method, which you will be able to get a healing. So the plaster is the only way in which you feel that it is contraindicated, but the stiffness doesn't occur because of the plaster. But if you give 6 to 8 weeks of plaster, stiffness does not occur. The range of movement will appear in about 3 to 4 months' time. Even in a plating, range of movement doesn't appear on the fifth day. It also takes 2 months to get the good range of movement. That's the reason I feel nailing has a place. Whether it is an exclusive place like Gadgone, I am not sure. But nailing definitely has a place in the treatment of forearm fractures which are not communal. Some of those other problems of nailing I'll be talking about in my own talk. I use a tense nail only because I think I don't have the access to Gadgone nail. And initially, and now it is available, but I got used to a tense nail. And I use a tense nail because it is easily available everywhere. You can cut it off wherever you want to cut it off. Like initially, the panel we used to have a very perfect length. Change with Gadgone length, nail you will have to have a perfect length. Other thing which I have discussed with Gadgone is nail has been put in. Now, last screws which you put in, the nail rotates. If the nail is jammed into one of the fragments, then the also the fracture will rotate. So probably it may be worthwhile if the conical thing which you hammer it in, so that the nail goes in. Because nail is screwing it out. Because the screwing it out, if it is loose in the whole medullary cavity, it will rotate and it will not change position. But if ever it is fixed up in one position or a distally, it has gone a little more inside and it is subchondral. And then when you move, the distal fragment will go on moving it. That's the reason I feel whether you can have a conical bolt, same way as you have got it, slightly conical, you go on tapping it, you can really fix it up at the end of it. It's just a thought you can think about it.
Oh, no, that nail is also available in the Western market, sir. That is they pass first the nail and then the screw is attached to that. It is already available and that nail is available. Okay, that nail is available. That nail is.
Anybody else has a question? Anybody?
Sir, most of the time when we are putting nail inside, usually tanks we are using, it becomes straightened in the radius, even after good bending of the nail. So how to prevent this problem?
It will happen if you are using a very thick nail. 3 millimeter or so, if you use a nail, the radius will take a very bit of straight up. It is the token a nail to really mold to the radial cavity. 2.5 millimeter is a good nail, safe nail, I think. The problem if you get in ulna is at times the ulnar medullary cavity is so small distally that when you will may not be able to pass a ulnar nail distally, if it is a thicker nail. So you may have to take by force a thinner nail, which maybe in some of those examples I'll be talking about. But what you mentioned, the bowing of the radius is goes away. That is only if you put in a thick nail. We showed it. Dr. Gadgone showed it where earlier I think it was done by a foreign surgeon. That he put in a thick nail and it will take away the bow of the radius.
Sir,
One
I am putting
one
2.5
thing.
mm square nails for so many years, and they have given no problem with union.
Sangeet, do you want to add up anything?
No, nothing, sir.
Sangeet,
Nothing, sir.
do you use nailing or you don't use nailing at all?
No.
No, he is a plater. He is a plater. I am not against the plating system. And I think it is just to tell you that the nailing also gives equally good result, 1 or 2% inferior. If those who are having a very good dissecting mechanism and everything, plating is also there, but it also requires some precision. We have to bend the plate to restore the radial bow and everything. So the knowledge in both the system is required to achieve a perfect result. If you use a straight plate into the radius in a curved bone, then again it is going to give trouble. So both the system works, but it is the technically they are all should be done very well, and then the results are comparable with the plating. But if you use anything like a plate, suppose if you use 2 screws, 3 screws, I can show you number of cases where mostly the both bone forearm plating or nailing, it is a surgical error rather than the error of that instrument and that fracture. It is mostly a surgical error. That means we do not accept that we are not able to do or execute a perfect plating or a perfect nailing. And therefore, Dr. Sangeet Gawhale and Tanna sir are going to enlighten us how to do a perfect nailing or perfect plating, and that is the crux in the union of a fracture. Because if it is nicely done surgery, literature says that only 2 to 5% failure rate after plating, and if there is a 15% failure rate is also described, because I have to present a presentation in trauma, and therefore I am going through all literature. The 15% failure rate of non-union is only and only because of the surgical error, not the error of implants or fracture. That's what I would say.
Dr. Neeraj has asked a question on the chat. Has anyone got experience with ulna plating and a radius nailing, especially in proximal third shaft radius?
Actually, this is one of the method described in the book also, and the paper also there, because it is very difficult to achieve a radial bow by nail, and therefore they do a open reduction and restoration of radial bow and bending of the plate, and they put a nail into the ulna. That is well described with a very good results. But there are also the same thing has said lastly, that it is a technically we are using one principle of a compression, means it's a rigid mode, another is a relative mode. So there is some problems in the healing of the healing pattern, because one here you have used a compression mode, other you have used the relative.
You are being sold out to the AO by the healing mode, compression and the retraction and the callus solution. What we are concerned is a good healing process and a good function.
Yeah, exactly.
It happens, it doesn't matter at all.
Can I add one thing, sir?
Yes.
Can I add one thing?
Yeah.
Yeah, actually, sir, in the very small cities, facilities are improving, and people are more and more going for the surgery for the forearm bone in relatively very small places, and plate is a rather demanding technique. So in that cases, nailing might be useful because of the standard, or you can say facilities are not that good in these centers. So here the nailing might be of better than plate, and might get the better result
You will
because of the. Yes, sir.
Yes, please carry on. I'm sorry to interrupt.
Yeah.
Please carry on.
Yes, sir. Yeah, so in these type of places, probably nailing has better off than plating because of the demand of the skill needed in the plating and inventory also. And the only thing is, one has to be very, very accurate with the nail to give the better and better result.
Let me
That is my
clarify.
take.
Let me clarify. Gadgone has not been doing nailing because his skills are lacking, and that's the reason he's doing nailing. He can do
Yeah.
he can do nailing really well. He's very skilled surgeon. So I think that skill is less, and that's why you do nailing is not acceptable to me. Because if your skills are less, you will also mess it up in a nailing.
Yes,
Exactly,
sir.
Sir, to tell you very frankly, plating is an easier operation than nailing.
I agree.
Nailing is mostly a closed method. We have to think of a canal, we have to think of a length, we have to think of a soft tissue reduction, interposition and everything. Plating is a very gold standard. You open it, reduce it, put the plate, give some bend if you are, and you apply 3-3-4-4 screws away from the fracture side. And pray God that the fracture will heal if there is no infection. Infection is the enemy of orthopedic surgeon in a both bone forearm fracture.
Dr.
Okay.
Gawhale, sir.
Any questions from the audience, Ashok? Is there anybody taking the questions from the audience?
Puneet?
No, sir. Till now,
Not
no
from-
question.
So, Gawhale sir,
Audience questions are directed to Dr. Puneet.
Okay.
I think we should move forward for the next speaker. Tanna, sir.
Dr. Sangeet?
Sangeet is next talking.
Sangeet, sir. Thank you.
Is it visible now?
Yes, sir.
Yes, sir.
So my talk is on complex forearm fractures. And in
What
that,
Your talk is on plating only, or it is any treatment?
only plating, sir.
Plating.
Yeah.
Please
So
carry on. Sorry.
the radius rotates around the ulna and it articulates with 5 joints which are involved in this movement. So it is also called as an articular fracture, and that requires always a surgery, particularly anatomic reconstruction in adults and adolescents. In children, the story is something else, which can be managed conservatively in most of the cases. So that is the significance. The displaced forearm fractures can be treated conservatively, but they have poor functional outcomes. And whatever surgery you choose, it should eliminate the external immobilization. So even if you have nailed it, your patient should not be in a plaster post-operatively. So that is the success of getting a good movement, a good rotation, and good function of the joints which are articulating in this fracture. Now, the plates which we commonly use can be used in different modes, and some of them have been already discussed, like a buttress plate or a tension band or a compression device, a neutralization, and in a bridging mode. Simple fractures, which are transfers, where the fracture ends are transfers. A compression plating can give you a predictable union and a good function in almost 98% individuals. So a clean fracture, these are old x-rays, so pardon me. So a clean transverse fracture like this, if you compress with a normal DCP in the diaphyseal fractures, will give you good results in almost all the individuals, where post-operatively you don't need a plaster, you can start mobilization, and before the suture removal, they are almost back to their normal function of the hand, forearm, and the elbow. So such is the predictability of plating these transverse fracture. And it can be reproduced in most of the transverse fracture as well. So fracture ends which are oblique, or there are loose fragments on one side, like here, or there is a wedge fragment which is still attached to either the proximal end or the proximal distal or the proximal end of the fracture. Here, many of us try to do an interfragmentary screw. In the bargain, we devascularize that segment, that small wedge of, or if it is attached to the bone, it becomes loose. It becomes devascularized. It doesn't have any attachment, and ultimately it ends up in an issue like this, where you have a defect, you have a fracture gap, and that leads to a non-union. So avoid putting a lag screw in these small wedge fragment or loose fragment, or even when you have a short oblique fracture. It's better to use it in a different mode, where you can use in a bridging mode. Here, you have left that comminution, you have left that fragment which is attached to the proximal fragment. You have not handled that fragment, that part. The vascular or the muscle or the periosteum is still attached to that fragment, and you can get a predictable healing like this in an expected time. This was a proximal almost proximal fourth fracture, where the plate has been extended right up to the neck by dissecting the posterior interosseous and the anterior interosseous nerve, and you have a good result. And the principle followed was of a bridging mode, and the patient has a good function. Sometimes in an elderly who have such a bad comminution, you can attempt, no grafting is required, just by plating and shortening, you can create an atmosphere where the comminuted fragments will act like a graft because you have not handled them, and that fracture will also undergo a good healing. So the principles which must be followed when you are plating is, your dissection has to be extra periosteal. There should not be any devascularization of the bone. You must try all the possible indirect techniques of reduction by using towel clips, not the reduction clamps, the big reduction clamps. There should not be used circumferentially. Just the pointed tips can be used to reduce the fracture. And if you follow these, you will get most predictable healing in these difficult situations. We come to the ends where we have a dislocation of the joint along with the radial fracture, the Galeazzi fracture. Here, the aim is not only to fix it anatomically, but to reduce the inferior radioulnar joint. So what can be done here is, you can put two provisional screws across the fracture and then check on the C-arm or the X-rays whether your reduction is perfect and whether the ulna has come back in its normal position in relation to the radius. And then you can add up the rest of the screws. So always watch for the reduction. Now, if you don't do that, what can happen? Many a time, you can see how you are able to ballot the inferior or the inferior part of the ulnar head, or the ulnar head or the inferior part of the ulna. So very often it happens that you forget about this injury because you are more concentrating on reducing and doing a good plating. So this should not be missed. In situations where you have a styloid process fracture associated with it, you have to do additional work to stabilize it, either with a tension band wire you can stabilize, or you can put a pin across in a reduced position, and then you can expect a good result after you have stabilized that inferior radioulnar joint in these types of fractures. Dr. Gadgone spoke about this. Now, the radius has a radial bow. It has a double curvature in AP and lateral plane. And this was described by Sage almost 40 years back. So there is a small proximal curve. It is convex, medial and on anterior side. And that angle is about 13 degrees. there is a large distal convex lateral, large distal lateral convex curve, and that angle varies between 9.5 to 6.4 degrees in the AP and in the lateral pictures. So two double curves, one small proximal and a large distal, large in the sense the area across is distal. So every attempt, particularly when you have a fracture at this angulation, you must attempt to reduce them and to take care of these two angulation or the two curvatures. Now here you can see this was again a Galeazzi fracture, and this is how it has been reduced. Now look at the interosseous space and the curvature which has been changed because of inappropriate plating. So this requires a revision where you reduce the fracture appropriately. Automatically, very often the interosseous space and the curvature is restored. So realignment, compression and restoration of the normal bow is a must whenever you're plating and taking care of the two distal curvature. We go to little more difficult fractures where there is an intra-articular extension. The distal metaphyseal fractures, where you have not only fractures at that level, but they extend in the distal articular surface of the radius. Here, always choose and fix the simple fracture first, where here what we have done is we have fixed the ulna first and maintain the length. Again, here in this situation, always compare with the opposite side, the rotation of the distal ulna and the length, whether you have achieved appropriately or not, before you fix and before you achieve the appropriate length. So fix the simple fracture, achieve the length here, as both radius and ulna both are comminuted, and then plate the distal radius with the appropriate plate to get a length and restoration of the inferior radioulnar joint. And this is the post-op X-ray. This was done just before the lockdown. I don't have his last X-ray, but he has sent me his pictures as I have advised, where he has a full function of the wrist. And I don't have his X-ray right now, where the fracture has completely healed. Whenever you're plating distal fourth, you require not such large type of plates which were available earlier. It is difficult to, particularly in small individuals, particularly in the female, to have an adequate purchase in the small distal fragment or to correct the rotation. Here is very difficult. So we have to derotate the distal ulna, which rotates by almost 90 to 180 degrees whenever you're reducing the low distal ulnar fractures. So here is a situation where patient had a non-union and there was a segmental fracture of the ulna. And this is how it has been plated. Since the patient was large, a normal DCP was used to address both the segmental fractures of the ulna, and you can see how the inferior radioulnar joint has been reduced. But now there are newer types of plates where you have more number of screws, 2 or 3 or 4 screws which can be passed, or there is an additional hook to the end of the plate wherein you can anchor it around the styloid process. That will give you additional purchase, and the 2 or 3 distal screws in the distal fragment, or you can switch over to this type of plates which are now available. So these are small profile plate which can be used, which are not subcutaneous, and you can address these low fractures accordingly with the newer implants as well. Now, as we have seen for the distal fractures, we move now to the proximal fractures, and one of them, like a Galeazzi, we have a Montagia fracture. Here, the key is restoring the appropriate length of the ulna. Once you restore the ulna, very often the radial head falls back in the normal position, and you can see here how the fracture has undergone a good healing, and you can see the patient has near normal movements in respect to the pronation, supination, and flexion extension of the elbow. And he has a good grip strength. So addressing and correcting the length appropriately will reduce such difficult fractures. Very often we come across these high proximal humerus, proximal radius fractures, which are comminuted. Now, the difficulty is the surgical approach. Difficulty is because of the comminution reduction, and what should be the appropriate implant of choice. The patient has a fracture of the proximal ulna. Patient has a comminuted fracture just at the level of the radial tuberosity. Now, while addressing these fractures, either you can use a standard Henry's approach or the anterolateral approach, or you can also address them by a Thompson's approach. For almost entire radius, you can use the Henry's approach. For the distal third, you can use a standard Wöhler approach. For the middle third of the radius, you have to release the brachioradialis, you have to release the pronator teres from the mid shaft, either or you can pass your plate underneath the insertion of the pronator teres, or release it so that you resuture it back to the lateral middle third at its footprint. So that is for the middle third. For the proximal third, what you can do is you can go proximally at the level of brachioradialis and the brachialis, and distally between the brachioradialis and the pronator teres. Here, once you open out, you come across the proximally the radial nerve, which crosses posteriorly as a posterior introitious nerve, and then you have the superficial branch of the radial nerve. You can directly visualize and protect the posterior introitious nerve. You have to release the supinator under vision, keeping the forearm in full supination, and derotate the head. You have to also release the annular ligament if you want to pass your plate that high in this region. So this is how it can be addressed. The plate has been contoured to accommodate the radial tuberosity, and the plate is almost reaching the neck. After fixing the olecranon, this is how it is addressed, and this is how the fracture has healed. The radius, which was comminuted, which was at this level, it has been plated. Patient has a full pronation, supination, and a good healing. Now, where is this radial nerve? Where is this anterior introitious, and where is this posterior introitious nerve? This is one such fracture where there was an extensive comminution in the radial shaft. The tuberosity was comminuted. Then radial head was very small fragment, and here the proximal radius was dissected right from above the elbow into the forearm. You can see the thick radial nerve, and then you can, in the next picture, you can see the division of the anterior, the posterior introitious nerve, and the anterior superficial radial nerve, and the anterior introitious nerve. Here, you can actually see them, retract them way out from your plating, and this is how it has been plated. You can see that is the radiological picture. After fixing the ulna, you restored the anatomy of the proximal radius by plating in that way. So such type of fracture can also be treated by the method which Dr. Gadgone sir has described, wherein you don't have to dissect anything, just do a mini open. This was done, I think, closed, and these radial nails can be used. But again, here you cannot address, or you cannot take care of the rotation part that very well. But patient has healed in spite of all that. The olecranon, the proximal ulna, which was comminuted, and here the bridge plate was used to fix the fracture, and simple nails were used in the comminution, even though we have not addressed the rotation part, but that fracture has healed very well. Another variety is the segmental fractures, what we come across. There are various ways without dissecting the soft tissues, you can address them. Fix in such situation here, there is a segmental fracture of the ulna. After fixing the plate, to the distal end of the ulna. Then what you do is you pass a screw outside the plate and use a distractor to distract between the screw, which is fixed in the proximal metaphysis out of the plate, and the end of the plate. So once you start distracting, the segmental fractures will position back in its anatomy, and then you can address and fix them with 1 or 2 screws in the segment and then some screws in the proximal. And here is an example how it can be executed. That segmental fracture of the radius has been, the same technique has been used here, where after reduction without dissecting the soft tissue, the segment has been fixed anatomically with a screw, and then distally couple or 3 screws distally to achieve a good healing here in this last X-ray on your right side. More difficult fractures are the one which have an open. Here the patient has come within 6 hours, and we did a plating after debriding. Since the soft tissues were good and the patient had a good envelope, we could reduce back here. That is the healed X-ray. The only problem here was the little angulation of the distal ulna here, which we could not take care. But in spite of that, you can see the patient's function, where he has a complete flexion extension of the wrist joint and full pronation, but his full supination, but his pronation is restricted by about 20 to 30 degrees. He has a good function. The radius and ulna non-union following a neglected treatment, following a plaster treatment here, can be addressed by the same way, where after correcting the angulation, there is a defect here which required grafting, and you don't require copious graft. You can take it from the proximal ulna, the cancellous graft from the proximal ulna, by making a window and packing it across the defect, and a compression plating for the non-union of the radius, and you can see how beautifully that has healed. The ulna which had a defect, only some cancellous bone from the proximal ulna has been used here, and that was packed in the defect, and the radius has also healed very well. So to conclude, the radius side can be approached by the various surgical approaches what we have discussed. Fractures as high as this can be addressed by a plating, where you achieve a proper rotational control of the proximal radius. Similarly, for the ulna, the surgical approach is not difficult. In the proximal ulna, what you require is your plating should not be on the medial side, because that is very close to the ulnar nerve. So it has to be on the lateral side. The only problem when you're plating the proximal ulna on the lateral side, you have to be careful about the LUCL, the lateral ulnar collateral ligament insertion, where you don't have to dissect much, or the footprint of the anconeus. You can slide the plate underneath the anconeus and the LUCL, or you can reflect and reattach them back in its normal position. In the middle third of the ulna, there is again not an issue. In distal third or the distal fourth of ulna, which is subcutaneous, you should not put plates on the dorsal side. You have to put it on the volar side, wherein you dissect the flexors, ulnar flexors, and then you have a surface which is flat, and where you can put the plates on the anterior side, so that they are not subcutaneous. When the patient touches the table, they don't hurt him. So these are the surgical approaches by which you can do a good exposure, a good biological plating, wherein you don't dissect much, and these approaches are safe, and most of the patients have a predictable healing if you follow the principle. Thank you very much for your kind attention.
Thank you, sir. Thank you for elaborate
Very good.
details. Sir, we can discuss it.
So Sangeet sir,
Yes.
Sir, what is your protocol in Gallagher fracture if in both of the conditions when we are getting the good reduction of the DRUJ without any ballotment and with ballotment? What is your protocol to treat these cases?
So
if it is stable after
if it
reduction
is stable, you don't have to do anything. You can mobilize them out.
Okay.
Till the patient has a pain, you can give a slap. After that, you can mobilize them straight away.
Fine.
In
unstable cases?
In unstable, either you can pin them and keep it in supination for about 3 to 4 weeks and start. When you remove the pin after about 4 weeks and then again start mobilizing them.
So you pass pin in the supination, sir?
Yes. Because the ulnar head will be reduced best in that position in the corresponding radial groove.
This will happen. This will happen.
Yeah.
Else if there is no length discrepancy. If there is a length discrepancy between ulna and radius, then the supination and K-wire will not function. So first and the foremost is you have to correct the length. After having corrected the length, then you can do this supination and put the wire and put it. That wire putting is from ulna to radius you go, then you are not going to likely to hit the opposite pole because the ulna is a small bone, the radius is a big bone. That may be probably the certain way of doing it. But you can still do it either way. It doesn't make a difference.
Sir, when we put wire, then it means we have to put on the plaster for few times.
I didn't get
when
you.
We are transfixing the radial. When we are transfixing the radial ulnar joint, then it means we have to put in the plaster for 3 weeks or so, whatever time you. Yeah. My second question is that in the small butterfly fragment in the radius or ulna, when you are fixing with the plate and they are avascular, it is said that you have to put you back in this particular position. What is your take for avascular fragments which are not so big, average size?
If they are devoid of anything, there is no periosteum, there is no muscle, best is to take them out and pack that defect with a cancellous bone, which you can take it because these are very small fragments. Unless your reduction is not normal, it is not appropriate, that small, or there is a defect, large defect, you require other graft, allograft or iliac crest. Otherwise, most of these small fragments can be packed with an adequate cancellous graft from the proximal ulna.
Puneet, you are seeing it from your iPad?
No, yes, sir.
Puneet?
No, sir. I am from iPhone, sir.
Anyway, very good presentation, Sangeet.
Thank you, sir.
Sir, I asked one question about the old neglected, which I put in the old neglected Montagia, which is neglected for months or maybe years. In adults, we do see this type of fracture in periphery. So what is your protocol? How do you manage the Montagia, which is neglected and quite old? How you manage the reduction of the radial head, or what you do for the radial head, and how you address the plating of this ulnar fracture in old neglected cases?
So very often what we require is getting an appropriate length. The radial head is dislocated because there is a ulnar shortening, or there is anterior, the ulna has malunited in an abnormal position. So osteotomy, graft, distracted, okay, and simultaneously, if the radial head is not coming, if it is beyond 3 months, it is difficult to get the radial head back. So you may have to consider excising it if you are not able to reduce it in an anatomical position, because that will always restrict the flexion.
Sangeet, may I ask one question?
Yes, sir.
Actually, I want to get a clarification from you. In a comminuted fracture, when you did assemble the fragment, and you said that the bone gap is filled by some of the bone grafts also. So you can use a compression plate, but how can you use a compression method as a for compression of such a comminuted fracture?
You
So
cannot
it is a positional. It is a positional plate or a bridge plate rather than it is a compression plate. Though it is a compression plate.
So usually, very often, only one side is comminuted, other is usually a transverse fracture. So on the fracture which is not comminuted, you plate first, get adequate compression, and on the other side you can do a bridge plating, not a compression plating.
Yes, sir. Yes.
In elderly osteoporotic, when they have that sort of diaphyseal fracture, usually at the same level you see comminution in both radius and ulna. In them, it does not make a difference even if you have shortened the radius and ulna, as which I have shown in one of my cases.
Can I ask you one question, Dr. Sangeet?
Yes, sir.
Dr. Nautiyal here. About if you have a fracture, transverse fracture at the bow of the radius, say middle 1/3, do you pre-bend or mold the plate first?
Very good question.
You recreate that.
Yeah. So very often what happens is the problem is when you're using a longer plate.
Yeah.
So if it is a transverse fracture at the level of bow, use a smaller plate.
Okay.
And always take a opposite side X-ray, wherein if you feel what happens is usually these transverse fracture are not transverse. They have irregular fracture surface. So once you match them, the radius falls back in a proper alignment. So when you're trying to put a straight plate at that level, what will happen? Your reduction on one side, either lateral side or medial side, will open out.
Yeah.
Okay. So in that situation, yeah. So in those situations, you will have to contour the plate or pre-bend the plate. Otherwise, if you use a shorter plate, they don't require contouring.
Another comment I want to make was you did say about the comminuted fracture, if there is a avascular thing. In closed fracture, there's no there is no danger of infection. Can you leave them as a bone? They will work as a bone graft after all, and put extra bone instead of removing it completely.
Sir, if you put extra bone, Dr. Gadgone will become angry.
Why?
It's a closed stitchless surgery today.
Okay. No, suppose you're plating it.
So we don't know once you're doing a closed nailing whether that fragment has any vascularity or not. It is subsequently, if that nailing goes for a non-union, then only probably we can predict that segment has become avascular, so that defect has not healed, and that is why it has gone for a non-union. So presuming that that is going to happen by a closed nailing, it is very arbitrary to put grafts in those situations. I would rather wait rather than putting graft at primarily.
No, my question was about the plating. You are plating it, opened it, you find a avascular bony fragment, and you did say that you remove it and replace it with a bone graft.
Yes,
my point was put it back, say avascular, because it is a closed fracture, and then put some bone graft around it.
Okay, I thought it other way.
No.
And a closed nailing, and you have I misunderstood.
No,
I'm sorry
plating,
for that.
Plating.
It is not an open fracture.
Yeah.
It was a closed fracture where you have done a plating and we have a fragment. Now that fragment is not going to contribute anything to the healing. So that is the reason I said you can remove it and pack it with a graft. So that will ensure that predictable healing is going to occur.
Yeah. About pre-bending the plate, can you give us some idea? Give me some idea about it. Where do you pre-bend and where you don't? Because usually in compression plating, DCP, we pre-bend it slightly. I usually pre-bend it so that the center is off the straight thing around 1 or 2 millimeter. That's how we calculate it. so that the opposite cortex is in contact. That was the idea.
Probably the distal radius or up to the middle third, the surface is flat. So very often in this zone, if you have a fracture, you don't require a pre-bending. If your fracture is at the little proximal, then in those situations, you require pre-bending. If your gap is significant, if there is a combination, or I would say you are not able to, you don't expect that you will get a good compression in those situations where you require more than 2 millimeter of compression. In those situations, I would recommend pre-bending the plates.
Thank you very much.
Thank you, Sangeet sir. I think we should move for the next talk.
Dr. Tanna sir, I would request you to please share your screen for the complications part.
I think I'm trying to work out my net. Just a minute. Just few seconds.
Yes, sir.
You see my slides?
Yes, sir.
Radius ulnar fracture complications. Now this is, I think Dr. Gadgone mentioned about the nailing. I wasn't fully there whether he mentioned about this distractor. This is Dr. Ajit Pal from Yavatmal and Dr. C.N. Kulkarni from Amravati. Did he speak about this distractor?
No, sir.
They have devised this good distractor. Here it is method of reduction, manual traction, Chinese finger trap with overhead traction device, CN distractor. But holding the forearm steady and holding the bones in alignment facilitate movement of the CR. So this is the distractor they have put in here. It's crossbar securing the hand. And this is the one which will give you the distraction. This is the actually put onto the table. And here is the counter traction which is given. So you can see it over here. This is the way they have devised. This is the counter traction over here. This is the traction which is of the forearm. All this is parallel and you can do like the DHS and fracture neck. They can really make this distraction. They both have devised it and it is very, very useful for this pure reduction of the fracture. So you can keep the traction and securely try to the transfer bar with the traction apparatus. Traction applied with turning the knots, avoid using distraction, over distraction and lightweight patient secured on the table. Now here it is once it is distracted and once the fracture is reduced, you can see the fracture is getting reduced. Traction is adjusted. Coming up. You can see so very well forearm traction is happening. The fracture will get reduced. And you can see the fracture. They will use this so successfully. And they've been using it all the time and that is available in some of the places in Maharashtra. This fracture is reduced to the traction. Now it is much more easier to do the nailing in these fractures. So in the post-op regimen, average hospital stay 1 day, post-op 10 days, evoplaster 4 to 6 weeks. Simple design, fabricated locally, economical, maintenance free. This is the one day of devising. Now I come to my complication. Forearm fracture is treated by closed or mini open nailing and open plating. Each one claims a superior result to the other. In a fracture, you can get this complication is the leg screw and somebody in the nail radius, there is nothing there, and then you can see there is a great convolution. For a complicated fracture, which beautifully Dr. Sangeet talked about, there is no option except the nailing. But you can see what happens. In such a fracture, you can also get a cross release. So the supination position is lost. Now here, in such a fracture, distal fracture, nailing is not very suitable for such low radius fracture. Dr. Gadgone mentioned about it. In this fracture, you can put in another wire and you may be able to correct it. Or not all the time, because the second wire, if it is to go, it is to go here, where there is no place for the second wire to go. As you can see, it is too tight. So the second wire can go only because it is loose here, but here everything is tight. So the second wire, even up to go here, is not going to be practically very easy all the time. So in a comminuted fracture, I think the nailing is not the ideal situation. If the fracture is better plated, we saw so many examples by Dr. Sangeet. Now, the record plate is not strong enough for a plating. It must be 3.5 dcm. You can see initially we used to use this record plate and it would break down. Everything was otherwise all right, but it would break down. So must use only a DCP and more thinner plates. Now here, this has been so beautifully plated and everything is fine. But probably I maybe do a nailing in this case, which is I find is percutaneous. I do the nailing thing that Dr. Gadgone has mentioned about it, but I use a tense nail as I mentioned to you. And I feel that once you got the reduction, you may be able to correct the rotation partially, but most of the time with the nailing, you will not get about the radial bow will not be altered because the nail will go unless and until the nail is very thick. Now here, ulnar medullary nail cavity is very thin at times. Ulnar cavity is so thin so that you will have to use so much thin nails may have to be used bending the nail. And the nail will bend. Dr. Gadgone mentioned about the reamers. I do have those reamers, but those reamers are not necessarily so flexible. And I have seen the reamer once you go by the bend, it tries to bend it and it breaks. So the reamer you can do only of one end. But when you try to go to the fracture, it cannot function very well. I do have the reamer, but I felt that reamer were used by me at least while doing an open reduction rather than the closed reduction. But when you're using this thin nail, it can bend. And if you are using only one bone forearm, other you felt it is good position and that's the reason you didn't nail it. One nail alone is not enough. And that's so in ulna, which is always going to be great. That's the reason if at all you want to fix it up, treat both the nails with plug. Whether you put a plate on one and nail in one is a different matter. I think it's a matter of choice. I have no objection in that situation. Only one bone nail in both the bone fracture is a weak construction. So this is the one which I will feel it should be avoided all the time and bending of the nail can happen. Now in such fractures, again as I said, in such fractures there is always going to be a malposition occurring here. So as Dr. Gadgone so rightly said, you have to pass the nail from this side. To pass the nail from this side, also it can probably correct. But it has to enter this medullary cavity. You can see this medullary cavity. The thin nail may be able to go. Here I remember I went thicker in order to correct this, but ultimately I couldn't correct it. It just needed to be left side. Fracture united, if you can see what has happened here. Because of the shortening which occurred in overlap, ulnar radial joint has been displaced. So there is if you get a position which you cannot correct by the stack nail, don't hesitate. Take out the nail and put a plate here. You will be able to get a good compression and the plate will be fine. And now here what was suggested was that if you are using two bones where one bone is in a good position and other bone is displaced, we have a mental tendency of fixing up a one which is well reduced first. And then you will not be able to get a reduction of a displaced fracture. Because if you want to get a displaced fracture reduced, also the other bone has to move a little. So what is recommended is first reduce the displaced fracture with the nail, whichever way you want to do. And by that time, the undisplaced fracture will not get displaced very much. Because it is undisplaced, purely because the soft tissue envelope is intact. And hence, first you fix up the displaced fracture. Once he has been fixed up anatomically, now you can fix up the undisplaced fracture, which will not get displaced dramatically because of the soft tissue intact. Now here is the radius which you have fixed it up. Now, I think this is probably the same X-ray which Dr. Sangeet has seen. I don't know my case or his case, whatever it is. Screws should not be near the fracture. This is absolutely no. This is the one ultimately was treated. Like this, you can see one screw which was shifted far away, and there were no screws over here. There is only one screw which is far away here, and this is the way it was treated. This is the way you got to treat this. Screw very near the fracture must be. My dictum is once in a normal, even a transverse fracture, I use an 8-hole plate and put 6 screws here, leaving 1 hole away from the fracture on both sides. The no screw nearer the fracture. Here was again the screw nearer the fracture. And it has to be put in such a way those the screws are a little longer, but this way in compression, you've been able to get the fracture very well reduced. The 2-part fracture fixed always either with compression DCT or with a leg, never without either. This you must do the compression. If you don't do the compression at the 2-part fracture, the fracture can go in for a non. Comminuted fracture is utilization at just all fragments indirectly in line with the fracture, fix away from the fracture. Do not hold them with the clamps on both sides. And you can just put this in the direction like this, and you will be not having a regret at all. Now, this fracture, as Sangeet has very rightly mentioned, short oblique fracture, never put a leg. If you put a leg, this is what is going to happen. This fracture will die out, and you can see this is the full sequence of videos of them. I think I got innumerable cases where this thing has happened. Such fractures, short oblique, never put a leg. Always put a compression. And you can use small amount of graft. You can take it out by this extraction drilling, which we always do. In the fruits of the drill, you can see quite a lot of bone comes in here. So you can take out this bone every 6-8 holes which you drill. You will be able to take out sufficient amount of bone from the drill, and if you are using a tap, from the tap also. Nowadays, we don't use the tap. And there is a bone which is collected here on the hole. That also you can take it out with the spoon. And when you collect, you will realize that the small defect in the forearm, this graft is going to be more than enough. Now here you can see here, this is the fracture which was treated, went into non-union, there is a gap here. All what he had to do was the compression. And it was my dictum, either side of the fracture, no screws. Such it is only three holes have been kept open because the fracture was extending so much. So never put a screw there. And never use the 6-hole plate. It's always an 8-hole plate. 2 screws you leave alone and put in these other 3. Now here, as you can see here, the same thing can happen. Now you see here, this is this very old X-ray. This is the fracture which was treated, went into lysis. 4 weeks, 10 weeks, still went into lysis. But the fracture is holding. No pain was there. So I held on. No pain, so I held on. 16 weeks. You can see from here, some amount of healing is occurring. You can see radiologically some activity which is occurring. Again, no pain. So I held on. And then if no pain of the treatment, and if the radiologically X-ray no union, hold on, it is healed most likely. And here it is 23 weeks, 28 weeks, 32 weeks, healed and complete. Such fractures where it is implants are holding and patient has no pain. Probably I have shown it in some of the CTs where the healing is occurring at one place. So you take a CT, you will be able to see that. Now here in such fractures will always do a plating, will never do a nailing, and there is unfortunate at times, though this may appear radiologically, it may not have been a cross union, but if there is no supination pronation happening, then this is a cross union, which is damn difficult to treat it. But the plating is the only way in which you can treat such a fracture. With such long oblique fractures, you try to do a nailing in a segmental fracture, this is probably not going to be giving you a stable fixation. Now here, small with good soft tissue, do not touch, no spike around the exposure, minimally invasive bypass plate. In such a fracture, you can see. You just do the bypass plate, no screws around, and you can see the whole thing heals up very well. There's not much of an issue. As you can see here, 6-hole plate, only 2 screws, no screws in between. 2 screws, 1 above, 2 above, and 2 below. It is still going to be a good construct. And here, your radial bow is gone. You got to contour the plate. This is what we were discussing just now. Unless you contour the plate, and you will not be able to get the radial bow corrected. Now here, this is a spatial situation. Upper one side ulna is a dicey fracture. Needs more rigid fixation. This was, you can see, this is a semitubular plate. In such a fracture, semitubular plate is not a good fracture. Is not a good construct. You can see this is the one which has been treated. You can't go up because you will go in the fracture. So he has put in these 3 screws there. This is treated now with the plate which is on the side. So it can take 3 screws bicortical. You can see 3 screws bicortical. This was the fracture of the head of the radius also. So this was excised and it was fixed. And so there was no stability on the other end also. Now this is the one where the plate has been put. And here you can see 6 weeks, 5 months, still no healing. 7.5 months, probably healing. And then it is 7 months. And this is what 18 months, long time to complete the healing. And this fracture is now completely healed up. And you can see the excellent function. There. So upper ulna, do not compromise. You can put the plate on the side so that you can get bicortical. Here you can see. You will not hear. You feel that you are going through the ulna. But the plate is like this on the side. It's not on the dorsal surface. It is on the side. So you can put a bicortical screw there. This I feel is the most important part. Here is the other fracture. Olecranon plate is not a good plate for this upper ulna. 33-year-old fresh fracture, olecranon plate. I feel olecranon plate is too thin for at this level. Again, the same thing. This fracture, it gave way. So I did a lateral plating. If you can see the lateral plating, I did the bicortical screws which have gone. And this fracture is held up. With a thick plate, bicortical screws, 6 screws, 3 screws proximally, and 4 screws distally, and the fracture heals up. KCP, DCP, board cortical screw, I feel a better construct in the upper one side ulna. If infected, this is a Talwalkar square nail. Now you can see this is what it is, 2 years. Patient got this infection or this redness. This is what is the radiology. You can see here, the nail is broken down here. Anybody has an idea what is happening? Ashok, you have an idea what is happening here?
So it's a failed removal, sir. It's a failed removal of implant, sir.
Puneet?
It's failed removal, sir.
Okay. Anybody else wants to add up anything?
Yeah, this is the metal lysis, the metal reaction.
Yeah, this is what it is. This is, you can see, this is all which has got a lysis. And I went down. This is what was this broken part of the nail came out because this was lysis. You can see this is the material which came out. This part of the nail which came out. This is the material which came out. This is the nail which was there. This is the material which was there. Scooped out the whole thing because this nail could not be removed. We scooped it out, put in the hydroxyapatite, packed it up, and hope that this will not give further reaction. Up till I had seen this patient till 4 years, things were fine, there was no issue. And this is how it was ultimately. Now here, these are some cases of metal reaction. See, I think today probably the metal used for these nails is very good. The days which were there, they were used to use the cheaper metal for the cost constraint. And you can see typical metal reaction happening here. You can see all this. Or you can see this metal reaction. These are the typical metal reaction we saw. Fracture healed up. But just because of the inferior metal, there would be a metal reaction. Here was the same thing, there was a metal reaction. And you can see all these things which is happening. Now in a fracture like this, if we miss out this fracture, the wrist X-ray, the wrist is a scaphoid fracture. So we know about it that we should take a joint above and joint below X-ray. Even I'm talking about just few days back. I was doing a distal femur nail. I did a distal femur nail, but when I opened up the knee joint in order to pass the nail, I saw profuse bleeding from there, which never happens. So we say, why is this bleeding? And here this coagulation and everything was normal. All of us said at the same time that there must be a fracture. So we took the CR, there was a Montagia fracture. The X-ray had not contained the knee joint. Same thing is here. X-ray didn't contain the wrist. There is the fracture of the thing. So you got to have a forearm when you take. It must have an elbow X-ray and the wrist X-ray. This was treated with the screw and the plate, and the things become perfectly all right. Now this is Dr. Sangeet's case. This is the infection. You can see this is the one day 1, 3 months first discharging. You can see everything is going haywire. The nail is now, you can see the lysis is occurring. 4 months massive discharge. He continued with the same thing for 4 months. And then this was the discharge. Sinus appeared 2.5 months post-op. And once you go down, there is a good amount of infection which is there. You remove the infection. You see the bone. There is no bone in between, which is bad. Operative picture showing viable bone after a debridement. And then this is the part of the bone which had to be excised completely. So it was temporarily excised, plastered, and then when the infection healed up, this part of the fibula was taken, it was put in, and again the replating was done after the infection and healed up with antibiotics and all. But you can see this is what has happened. So he could not correct this. So there was an ulnar shortening. Now this is, will come to, this fracture is 3 months, 4 months, and 10 months, the fracture healed up. But once the fracture healed up, there was an ulnar 10-month post-op patient without plaster. For last 4 months, the radius fracture held up. But since the length was not obtained, ulna became an ulnar positive end. Now this is the one which can be well treated by shortening of the ulna. In earlier days, we used to do the direct choose operation here, excise it, lower it as the ulna, which is now it is not done. Even substantial fusion of this was done with the pseudoarthrosis there. That is also not required. You need the ulnar shortening. That is the today's operation. You remove the part of the bone, get this ulna back over here. And this is the one which will give you a good wrist. As you can see mine, I had an ulnar shortening done for my fracture and it's a perfectly 100% normal wrist. Now this is 10-month post-op. You can see supination, pronation restricted. Now this is 10-month post-op patient without plaster for 4 months. This is a positive ulnar barrier, ulnar shortening. And this is what it was. Obviously the patient at the end, the whole infection didn't want anything at all. This is a 44-year-old. This is also somebody's case. I don't know who's 44-year-old surgeon from Nepal admitted with a fracture both forearm, 2-year-old. He was operated with the DCP, had a severe pain, restricted CRP infection. You can see that these were the only accidents which are there when he presented this. You can see the huge amount of pus here. Now, how do you go back? First and foremost, as all of us know, pus removed, then this bone was excised. As you can see, this dead bone was excised. This dead bone was excised. Now, the whole infected bone was removed. If you can go back here in the X-ray. This is the bone which was removed completely. Now, after having removed this bone, this is again the beads, antibiotic beads, kept it away like this. The ulna has been dated, so this the radius length could be maintained, and the fibula came in, the K wire came in, the external fixation, 6 months now out of fixation with 4 months. And this is the one where you can see the healing is occurring. So this infected fracture can be treated this sort of a way by various ways you can treat them. And you can see this thing is held up with a fairly decent function in this infected fracture. This was another infected fracture. Both bones have been gone. The surgeon put in again the fibula on both bones, put in the Alizarao as an immobilizer with the K wire. Probably the plating could have been a better option, but in that part of the world, he didn't want to do the plating. And ultimately, this is the one where the fracture held up. So if there is an infection, it is also very easy to treat the patient in the best possible way. Nailing and plating both works in its own indication. Radial bow is very important. Do not neglect that. Do not put screws in one hole on either side of the fracture. Infection needs multiple surgeries. And unless and until you treat the patient completely, you will not be able to get the best results out of the complications which you will get out of that. Any questions?
Sir, may I ask a question?
Yes, yes.
How much length you can use that sandwich graft of iliac crest or fibula for a bone gap? This is pre-fibular graft or iliac crest graft? How much with your expert, because it is a textbook says it is up to 5 centimeter gap can be filled up with the corticocancellous graft. So what is your experience up to 5 centimeters?
2.5 inches, that is the highest which I have done. But after that, you are never sure that it will heal up at one end, other end will not heal up. So what I have been doing it is I put in the fibular graft in the plate, put in the autograft on both the sides of the fracture. So it is like an overkill when you do it with complicated cases. So you don't keep no stone unturned, do everything at one time. And probably whatever is going to work, it will work, and the patient will be all right. But as you very rightly said, a long graft doesn't work. Long graft is being done in a femur. If there is a loss of femur bone, either because of the accident or because of the infection, you can use a long fibula graft, about 5-6 inches graft, and then supplement it with the cancellous graft all over, and support it with the plate. Probably that is the one which is work, because you put in a lot of graft to support. And the autograft plus the allograft, you can support that graft. That's the one which is probably going to work in that situation. But in a forearm bone, it is only 2 inches, because you generally don't need more than 2 inches of graft.
Sir, may I ask one question, sir?
Yes, yes.
In the cases of when we put a square nail in the ulna, which is still quite common, and the commonest complication is prominent of this nail is protruding out or breaching of the skin at the insertion side of the ulnar nail. So how you manage this? Everything is fine, but you need to...
Ages back, I have changed over. I don't put from the tip of the ulna. I don't. I go on the side. I make a cut like that on the side, make a passage, and then put in a ulna nail. The tip of the ulna we have to put in when we used to use a square nail, which will not be able to bend. So when we are putting this dense nail which I am putting, which can bend, so you can go like a radius. So typical, even when there was a square nail was being done, I would do the radius nail for the ulna, because I wanted to go from the side. I wanted to go from the side and bend it and go. And that's the way the nail doesn't walk out. If it is from the tip of the ulna, then it will walk out from a bursa, and it will be a very painful and unnecessary complication. Because if it is there, nail which is there, even if it goes into delayed union, the patient doesn't get a problem. And as I showed in some cases, slowly the fracture hits them.
So how you manage, sir, when you see these cases, when there is a nail in situ, it is protruding or just breaching the skin?
I think
and
there is no point in keeping it, because it will come out and it will infect the fracture. So what I advise them is I go down, take out that nail and pass the nail from the side of origin which I mentioned to you. And then if at all the fracture is not uniting, I will also overkill and put in a graft. Non-unit side or whatever the side.
Sir, is there any harm in using radial nails in both the bones?
I have never found that problem. I have never found that problem. We are talking about when we were using a Talwarkar nail. When there was a ulna nail was a straight nail, which was and the radius nail was a slightly thinner nail. That ulna nail, which was a straight nail, had to be passed from here. So I had always used the radius nail from both the bones.
Sir, I am also doing the same. I now use only radial nail for radius as well as ulna.
Perfectly correct. Perfectly okay. The bones don't realize whether this is a radial nail or ulna nail. We have given them the name. And this nail, we put it in the same nail. Or what Gadgone does is the same nail for both radius and ulna.
Dr. Gadgone,
Yes, sir.
where this nail is available now that you are
Now,
Doesn't sell to any one of us. He wants to create 100 cases first, and then only you and me will be able to get it.
no. Now it is available. Now it is available with each and every company because I have made it so popular. So many people are using it now.
so which company, sir?
Yeah, it is available with the Sharma Surgical. It is available with Nebula now and available with Kemsarth company. I will tomorrow WhatsApp the number.
Okay. No, I have got numbers of all these.
Gadgone, have you observed that when you put in the screw at the end, that if you see it on the CM, I have seen it, whatever those one or two which I tried to do, the fragment, you will see that moving, rotation occurring. So have you observed that since you have done so many?
Yes, probably that is a apprehension that it will move around. But what we do, we calculated that diameter we less than 5 mm. We use it, so it goes smoothly inside. And the last part is screwed, not the whole the screws. Screws are used only in the last 1 centimeter only, sir. So therefore,
also when you put the screw,
yes, it is possible. It is possibility is there.
The whole
Possibility.
plate is rotating.
Possibility is there. Possible.
Can't we hammer a wire
In the radius, in the radius, you have to hammer it. In the radius, that screw is for the last thread only. Rest of the thing is done by the slide blow.
But have you felt like making it a small conical so that you can hammer it down and you don't have to screw it down?
Yes, I got the idea from you today. So probably next I will give the idea to the manufacturer.
I feel it may be far safer. That's how I feel. You have a large experience of that, so you know the things very well.
Sir, actually, I will use your small video while presentation in TraumaCon or non-union of the radiation ulna fracture. So for your permission, I am asking.
Which video?
A small video of both bone forearm decortication and putting the graft at the fracture.
Yes, I think.
So
as I said, every non-union main operation is singling. The singling above and below which you do it, that is the only one which will start the whole healing process. You used to put only graft without shingling, then the graft will get absorbed.
So actually, your method has been copied by one of the author from something. Actually, it is an article in the SICOT journal in the July it is, and the same method he has described as you have described, totally same with the drilling and keeping creating at the end drilling and some creating a small micro fractures and putting a position. तो लेकिन बहुत it is a सुंदर मैं आपको I will send tomorrow the print of that article. So this method is already, he must have heard you, and he has written an article, beautiful article on it.
Okay. Yes, Sangeet, you want to say something?
No, a case I wanted to show, which with reference to the question Dr. Gadgone has asked, what should be the length of a graft?
Yes, sir.
बता दें.
Can you see this?
Yes.
Yeah. So this individual was operated. He's 26 years old. He was operated elsewhere. That is his right dominant hand. And he presented in November 18 with pain and restricted dorsiflexion. Probably the nail is through the Lister's tubercle here. And you can see what has happened. He comes after a year with no pain. but still his wrist movement is restricted because obviously the tip of the nail is impinging the scaphoid or the other carpal bones, and that is the reason he is not able to extend the wrist. But you can see here what has happened. There is a shortening of the radius and the ulna is overriding here. So that was what was symptomatic. And we said, we will just remove your nails and you will be all right. He comes back after a month as his movements were not improving. And that is his wrist X-ray, where the radius is shortened by almost a centimeter here. And that is his large view. So what would be the option here? As Tanna sir said, we can shorten the ulna here by almost a centimeter, if that is okay, or something else should be done here, or excise the ulnar head.
Or you can really lengthen the radius.
Okay, okay. Gadgone sir?
Yes, sir.
What should we do?
Actually, whether the patient is functionally disabled or it is just a cosmetic appearance, but you said it is a 25 years old, we must do something. So that in this case, suppose the radius is now already united, I will prefer a radial ulnar shortening rather than doing something for radius.
Okay, okay. We chose the other way, where that is the overriding of the ulna, and we wanted to correct it. So what we did was, by a volar approach, we did a oblique osteotomy through the heel side. And if you are aware, in the cervical spine, we use a Casper retractor, which have short pins. And then this is the Casper retractor used for distraction of the cervical bodies when you are doing anterior discectomy. So I use that like this and gradually distracted that osteotomy site to the extent that I got an appropriate length of the radius and ulna. I fixed that with a K wire so that my achieved length is maintained. Now you come back to the graft which would be required here. So it is almost a centimeter as what we had calculated earlier. And that is a site, that is a size of a iliac crest tricortical graft, which is almost matching the normal radius to the defect site. So that is how it was impacted. And after impaction, we removed the distractor and fixed it with a plate. No compression. And this is the post-op picture where we are able to maintain the radial height. And at 3 months, this is his function. And this is X-ray at 1.5 years, where you can see a complete incorporation of that iliac crest tricortical graft.
Wonderful, wonderful, Sangeet.
Can I show one case?
Yes, sir.
Just now we were talking about Montagia elbow dislocation, plating that. Comment.
Yes, sir.
Radial height is still dislocated anteriorly.
Yeah, what has happened? What has happened? Why it is dislocated?
Bowing of the ulna. Ulna is still bowing.
The length
It
is
is not corrected.
Ulna is?
Ulna bowing anteriorly bow.
Yes. Those
It is not straight. Ulna is not straight.
So immediately for 3 days time, I went and I bent the plate.
Yeah.
I bent the plate and got this ulna back here. And the radius just comes back. You can see the radius comes back. Like united, in there, and this is the was very good. So I think when you're doing a Montagia and ulna plating, I also identical second case which I can't find it just now. Identical thing happened. So it is mandatory to bend this ulnar plate in order to get the fraction. Same thing what we used to do in a Montagia, which is dislocation. We used to do this, but in a fresh fracture, if you don't do it, it can become exactly what I did it first time. It can happen. Okay, friend.
Okay. Nice lesson, sir. So I hope that we have become a little wiser after the end of this session. And
इधर तो मुन्ना भाई बहुत कंफ्यूज मेल करे के प्लेट का
More study, more confusion.
Yeah. Two powerful speakers. Two powerful speakers have given the position of nail and plate. क्या करने का मुन्ना भाई really confused. No answer. Anyway, good one. Thank you, Ashok.
Sir,
Thank you, sir.
I have to give an announcement, sir. Our next symposium on 11th will be on pediatric orthopedics, and we have kept only female speakers and female panelists. So that will be that will be some more attraction to the symposium, and I'm thankful that Dr. Shobha Arora and Dr. Rujita Mehta have consented to be speakers in that. So I am again thankful to Maharashtra Orthopedic Association for the next symposium. And thank you very much, sir, Dr. Tanna, sir, Dr. Gawhale, and Dr. Gadgone, sir, for taking giving your time, and it was very nice. Dr. Puneet will give a formal thanksgiving from the Uttaranchal Orthopaedic Association.
Thank you, sir. It was a very nice evening, sir. It was nice. Thank you, Tanna, sir. Thank you. Sorry?
Good night, sir. Good night.
Good night, sir. Good night, sir.
Namaskar.
बोलना ही पड़ेगा कि अच्छा सब Okay, good night.
Good night,
Good night, sir.
Good night, sir. Good night, everybody.